So I think it's worth pausing for a moment to appreciate the fact that now most people around the world, including in the US, seem to agree that universal access to health care when needed without risk of impoverishment is a great idea. And I think, it sounds like it's easy to say that. It's motherhood and apple pie, as we say in the United States, but it is actually a huge achievement. And it culminated at the UN General Assembly meetings, high-level meeting, where they passed a declaration. But the next thorny issue on the agenda, after we've decided, okay, that's a good idea, is who will pay and how much? So in a first best, in that ideal world that we'd like to live in, countries are growing very rapidly. Their revenues are growing rapidly alongside. Government is able to facilitate or directly administer a prepaid pool of money that is large enough to cover all health risks, a comprehensive set of health benefits, prevention, promotion, and related. That's the first best world we'd all like to live in. But we don't live in that world yet. So the question is what to do in the meantime and how to get from here to there. So in today's world, we know low-income countries are spending much less than required for a basic set of health care. Our friends at the World Bank estimated that $105 per capita per annum are required. They're currently spending $40. Aid makes a big contribution, but it is not fully deployed in support of the most cost-effective services. We have the persistent problems of aid coordination. There's still a lot of money out of country, off budget, persistently siloed by disease. And then at the same time, we're asking some lower middle income countries to transition from aid and fund a larger share of these sets of services, but they've been busy funding some of those services, but also some other services. And so we're actually asking them to reallocate in a very tough fiscal situation. On the other hand, low middle income, upper middle income countries, they're spending enough conceptually, but they're not fully financing the full coverage of the most basic set of cost-effective health services, and we're seeing less than optimal outcomes in too many places. We know that more government spending generally is associated with less out-of-pocket spending on health, but not always. We have countries like Brazil that have a very large public sector outlay, a very well-functioning health system, and they still spend half of their total health expenditure out of pocket. We have poor communities and people that systematically receive less public monies per head and fewer services despite bearing more of the health risks. And that's true in almost every country of the world. And if public subsidy today reaches the relatively better off and not the poor, is our idea to ask for reallocation from our leaders or to increase the overall pie? Are we allowed to charge the rich or are we not allowed to charge the rich? I saw a panel. I don't know if anyone from Oxfam's here. Are you here? Okay, we can talk about them. No, this is being webcast. But they had an event with the IMF where they were discussing that no user fee of any kind, even to the wealthy, is permissible. So we'll talk about a little bit of this as well. There are some extremely difficult financial trade-offs between responding to huge demands today and what we need to do to prevent more demand tomorrow. So something like, I have to spend on dialysis today instead of on the prevention of end-stage renal disease. And of course, inefficiency and waste. So as we join this IMF World Bank Week, and with this incredible panel, and we have the Minister of Finance of Egypt, who was previously the Minister of Health. That's a very unique person that is sitting in the middle of our panel. Yes, so we're really, really pleased to have him join. We have Dr. Dinesh Arora, who led the National Health Authority as part of the Prime Minister Modi's very large health insurance reform that is ongoing. We have Dr. Mohamed Pate, who led Nigeria's huge primary health care reform. And we have Dr. Henrietta Fore, who is the director of UNICEF. She has been the director of USAID. It's truly an exceptional panel. So thank you all for joining us. So I'll turn first to Henrietta and ask you, we've seen these really important calls to action at the international level, but what do you think will it take to move from these mobilizing moments to more concrete progress together? What's going to change in this next phase?
Amanda, it's a great question. I think it's one that we're all struggling with because you see this enormous need for primary health care and for universal health coverage out around the world, and yet we've made commitments and we're not acting on them. So what we need now is to take action, to start putting it into real concrete programs, to get money behind it, to get people behind it, and to really start moving. Since we have individuals here who've been deeply involved in countries, making country-level commitments can be very important, such as in India, the Clean India program, to end open defecation. That changes people, it mobilizes people to do something about the general health. But health, at this moment in time, has to be thought of as being very multi-sectoral, so nutrition, and health, and water, and sanitation. So that makes it difficult, but it will make it much more powerful. Mm-hmm. So we need to get to work.
To get to work. Okay, so more money for health. Dr. Pate, your World Bank is the one in your G20 report, you highlighted this discrepancy between the amount that's needed, the amount we mobilize now, the need for aid to work better together. What do you see as the next step after these big mobilizing moments?
I think before we came on stage, I had a chance to ask the Minister of Finance of Egypt. I think it's key that country leaders make the decision to translate these global commitments that have been made into actions at the country level. Where you see that, like Egypt, India, there's something behind it. And it's that determined action by political leaders at the national level that will make this happen. It's not what we do at the large gatherings alone. Mm-hmm. The analytics has pointed the way, that the resources aren't enough. We've set a target that many countries are not going to make unless we do something differently. That includes national leaders devising their path, how to get to universal health coverage with their resources, but also how we as development partners organize ourselves to support around their priorities. Mm-hmm. And so the Global Action Plan, for instance, that came out of at the UN, basically enables us to see how international financing partners can work better around countries, around their priorities, around their national budgets, focus on results. We also need to look at the efficiency gains. Where are we going to make them? Because as you mentioned earlier, in some areas there may be wastage, in some areas there may be opportunities to improve the utility of those resources that already existed. And that's an important element of it. Raising the resources more broadly, improving the collection of revenue is also a key part of it. So it's a multifaceted issue, but that at the center of it is what nations decide to do. And I think we have good examples how that has actually translated into increased resources for health. And that's the way that we'll reach the UHC. Otherwise, we're setting up ourselves not to achieve what we think is our goal.
Excellent. I'm going to come back to both you and Henrietta on this SDG3 accelerator question and how, if you could give us some examples of concretely how the different development partners are working at country level. But before we do that, let's turn to Minister Might. UHC has been declared a priority in Egypt's strategic vision. In our previous talk, you were speaking of the difficult political decisions that have to be made in the sector to be able to move forward with universal health coverage. Can you talk a little bit about those challenges and how Egypt is addressing them?
Thank you very much for that. And the commitment is not just to say we're going to do it. The commitment is a package of all the elements which can translate the commitment to implementation, a process of implementation, and the insurance that this process of implementation will be able to continue. You can make the commitment, say, as a popular decision, I'm going to adopt the universal health coverage and I'm going to do it. But when you translate this to action plan on the ground, you will find that, oh, I'm not able to do it, or it is done in the wrong way, or I don't have enough infrastructure, or people, or IT, or management, or technology, or enough doctors, enough medicine, enough. So it's not just I'm making a commitment, is how to translate this commitment and ensure this commitment, when it is implemented on the ground, it will achieve its objectives. Because I believe many have made the commitment, but they were not able to implement. Egypt stayed 15 years studying the introduction of universal health coverage until they come up with a design to ensure this design, when it is implemented, it will be visible and efficient, particularly that Egypt is not coming from zero.
Right.
Egypt has been implementing health insurance for 55 years. We started 1964, but after 55 years, we found that we haven't implemented the objectives. So we analyzed why we didn't. We analyzed the reasons, and we learned from the experience in designing the new system. As a result, we saw financing is one of the most important issue. We have to ensure that it is going to be solved, and this is one. Number two is the structure of managing this system. If it will be depending every year on the allocation in the budget, I can assure you it will not continue. It will not. But if you find a way this system can be managed as a sustainable system, which is not depending on the decision of the Minister of Finance or Minister of Health or the Prime Minister, I believe this is the first step, the right step. Number three is to ensure that not all the functions done within the government departments, but by agencies which have some sort of independency, and they can manage it in a professional way for the benefit of the country, not for the benefit of the politicians, just to say, oh, we are popular, we've done this, and after they leave, it is collapsed. So we've taken all of that in the design, and when we presented to many presidents in Egypt, everyone was afraid of the financial consequences until President Fattah al-Sisi said, I'm going to adopt it, go to the parliament, and the law was issued last year in January. Since last year in January, we were preparing until we started implementing in July this year in the first governorate. We have 100 million people, and the rolling out will be over 15 years. But we said, let us move in a parallel way, rolling out of the new system and strengthening the current system, so when they are integrated in each governorate, like one is handling to the other one.
I mean, that's a common problem, that you have two systems coexisting at once, but you've been able to articulate what the path is to the unification of financing and benefits. Is that right?
When we go to any governorate, the old one with all the current structure will be handed to the new one with a specific transitions. Let me say, when we designed this system, we said, okay, let us design it not only an introduction on universal health coverage, but as a health reform, because Egypt always we got this statement from the international organization like the World Bank. Egypt has a scattered health system, a lot of organizations, a lot of entities, blah, blah, blah. We said, no, we have to integrate all these entities in the new system. So when we go to any governorate, the other system, other programs will disappear in the new system with a transition, how to move from the current to the new.
And I'm sure there are a lot of politics in that process, right? Because each one of those subsystems had their own financing.
Exactly.
How you moved some of those functions into a semi-autonomous agency, but also the Ministry of Finance had a special role, right?
I'm the chairman of the financing agent, not because I'm a minister of finance. It's just a transition because they want someone to lead who understand how this will work. But we are assuming that the financing should not depend on one model, because if you look at the experience of some countries, look at Europe. When you are talking about financing through social insurance or social security, with the aging population, I think if you look at Germany, is increasing the required contribution over time, because with elderly living longer, so the cost of health will be higher and you need to get somewhere. We've said we should not concentrate on one type of service. Some countries, UK, no, it is from the budget. So once you have the burden, you have to increase the taxes, okay? Some other countries designed different way of financing the system. In Egypt, we decided to take all these methods together. So part will be through social insurance contribution. Part will come from the state budget by reallocating resources. We have 600 hospitals. Each hospital has a budget. We've said, no, we're going to take these 600, upgrade them, and give it to the second organization, will be the public health provider, out of the budget. So I'm going to redirect the resources, the budget of 600 hospitals, which provide health services not satisfactory to the population. So I said, I'm no longer financing budget. I'm going to finance services, services for the citizen. So whenever the citizen will go, I'm going to pay the cost. We'll go to private hospital, I'm going to pay the cost. Because my role as a financing agent is not to finance a budget of salaries and operating expenses. I am financing health services for the citizen. So if the citizen are happy to go to military hospital, university hospital, private sector hospital, private hospital, anywhere, I'm going to finance the services wherever the citizen will go. Because this is my role. My role is no longer to finance budget of hospitals when the people, the occupation is 10, 15, 20% maximum. The occupation of the hospital. So we pay salaries for those people who don't work.
Yes,
so,
and this issue of then what do you do with the public infrastructure that you don't use anymore is, I'm going to come back to you on that. But this is, I think, a perfect segue to Dr. Dinesh, because India has executed quite a similar reform, I would say. You've had your own difficulties in terms of, well, who pays for primary health care? Is it you? Is it someone else? Can you tell us a little bit about the National Health Authority and how it's managed some of these same issues around switching the payment mechanisms, how it intersects with those subnational governments like the governorate in Egypt or the state in India?
Absolutely. I think I was so amused and so thankful, Minister. The way you were articulating is any civil servant or bureaucrat would love to have a minister like this articulate these feelings. Thank you so much. And we had this.
Can you work here? We need you. Okay,
so I just wanted to say that, like, on February 1, the Prime Minister announced Ayushman Bharat. It's a paradigm shift where we went from a supply side to a demand side. The Prime Minister also felt the same thing, that we need to put in resources where people get benefit, not for hospitals, but for the people. And it's a people-centric scheme. 16th February, we called all the states, had discussions with them. What do they expect? So the stakeholder consultation started. So India brings on this table how to do this now. We have completed 1 year last year, and the numbers have been amazing. 110 million people were reached in the first year. 5 million people got treatment. We gave treatment worth about $9 billion to the people in the first year of implementation. And so we had consultations. On 21st March, we went to the cabinet, got the proposal approved. 15th August, we launched the pilots. 23rd August, the whole scheme in the first round for 500 million. We have got about 20,000 hospitals empaneled with 10,000 private hospitals. So it has been a substantive ground in the first year. Now, if you talk about the impact will come over the years. If the impact for this scheme was to decrease out-of-pocket expenses, if the impact is to decrease catastrophic expenses, it will come over the time. But the output indicators have been fantastic. What this scheme has brought to the forum for a UHC is a demand-side financing. Till 70 years, we had been doing supply-side, pushing money into the hospitals, giving money, and you will be surprised that our public health sector in rural areas, other than MCH services, utilization was 10%. So what now this scheme does, it empowers the poor person. So the scheme is for the 40 bottommost percent of the people, 500 million. They can choose any hospital they want to go empanelment for all the hospitalizations. And it has done fantastically well. One good thing, which if you ask me to take one thing which I can proudly say something, is an IT system. Now we also have, Minister,
cool.
the
I've
core.
seen it. Yeah, very cool.
It's like something which perhaps is going to take us forward. We brought in data champions here. We became evidence-based policy machinery here. Each and every hospital is connected on the same software. Hospital, district, states to the National Health Authority. Dashboards across the thing, transparency, package rates are fixed. Anybody can see that. So if we have an accreditation agency, if we have an agency which is a hospital provider and one which is a financer, same system they are looking at. And that brings transparency to the whole, and which when the Prime Minister sees those figures, he says money, he will give money for this because he can see the people getting treatment. When we used to report earlier, the treatment was these many cases done. Today, 10,000 cataracts done. In India, 10,000 can be done in a day. Its population is that big. But today, we have each and every area lined. Which area, which thing, which eye, and we can do the full analysis of which age group we done. Had they done it earlier? Was there a double dipping? So I think one thing which I can pick out of this was a data revolution, which became a part of this scheme and which is going to go further.
Let me ask you, Mohammed, now this issue of buying into both the public and private sector is something that we see in hospital services, but a little bit less so in primary health care. Do you see, and I know that there are a lot of reforms that have payments for primary health care, usually through government entities. It's the same in India, that's remained the same. Can you talk us a little bit through the pros and cons of that? I mean, and it's interesting to think that in a place like Canada, it's actually the opposite, right? All of the hospitals are public on budgets, but the primary health care is private and competitively provided. So I don't know if you have any reflections on that issue of primary health care in these reforms.
What are we solving for? I think we are solving for UHC as a way of improving health outcomes. And that requires not only access, but also quality. And if you look at where we are going, I think we're sort of not as much pushed on the quality agenda as much as we can. And that by itself will get us more for this current spend in terms of health outcomes. Then where do we spend it to get the most outcome? I think you could argue that primary health care is the aspect of the overall health system when you have constrained resources that you get more for the resources you have spent. And if you do it at quality, you would get better health outcomes linked to an integrated health system that also links to what is provided at a higher level, the hospitals. So when you purchase, I think you purchase the services, but also at the quality that is needed at whatever end of the health system, but that is an important element in it. The purchasing function from the public resources, whether in Egypt or India, I think ought to consider what models of private service delivery exist and how do you optimize in terms of what the public gets out of it, in terms of value, in terms of health outcomes. So you would have heard our president at the UN high level, he made some remarks regarding the private sector role in service delivery. I think that's something that we ought to, the reality is that even in the poorest countries, there is an active private sector that's out there. Oftentimes it's not well regulated, and the structure of financing or for the services is not organized in such a way that gives you the optimal services as well as the quality. And we need to do more in terms of that. That will get us more with the resources that we are spending, in addition to the argument for more resources to be brought in as we move towards UHC.
And what do you think about, and one thing that many have commented about in the PMJY reform is that, primary care is separate. It's not necessarily integrated into that hospital reimbursement scheme that has been brought into play. What would you respond to that?
Absolutely, Amanda. I think
and he's no longer a government employee, or you're on leave, so maybe that,
right,
I don't know,
John's
say what you'd like.
Okay, no, but I know if I would have said the same thing there also, and I'm known for speaking like this.
Okay, excellent. Go for it.
And if you see the whole continuum of care, where do you want to treat somebody? You will like somebody to fall sick and then give treatment, what is presently being done, or will you like to give a treatment at the initial step? So the Ayushman Bharat came up with a good philosophy of two. One is the primary health care, 150,000 health and wellness centers. And the second was this Modi care of reimbursement-based demand-side financing. But I certainly believe that this needs to have a more close organic linkage. We will need to have a sustainability of the schemes only if we catch people earlier. And for this, we need to change our models. So what India is right now doing is in impedency, in the first step, we have implemented the Modi care very well in the first year. We are going forward with it. But we are also designing pilots. How do we link primary care with this? can the National Health Authority, like authority which is getting Egypt, should also purchase primary care, and why not? If we are acknowledging the role of private sector in secondary and tertiary hospitalization, which is about 2% or 4% of utilization rate of the whole health system, why leave out the 80-90% of primary care? Why primary health care cannot be purchased? Politically, seems people feel that government is washing its hand off, but we must understand the role of government is provisioning of services, providing services. At times, government does pretty inefficiently. So I think what we are right now doing at India also is, so I'm on leave, so it's my personal thing, but what is being done right now is carrying on pilots in many states. How do we link primary care? In some places, even NHA working as a purchaser of primary care, and come up with a model, with a capitation model, whichever model comes, and then perhaps we'll go forward with that.
Maybe I could ask you, Henrietta, to reflect a little bit on sort of primary health care within the universal health care agenda in the meetings that I'm sure that you have been attending over the past couple of months. How have these issues been addressed, and what would you like to see going forward?
So I think we need to raise the issue of primary health care, and you can hear it from the doctors here. It is something that is very real to a family, it's very real to a community, and it's very efficient as an investment. And so when you look at that, you just think this would be an area that you could really take care of much of your population. UNICEF sees lots of mothers, those that are prenatal, those that are postnatal. And for mothers and newborns, this is just a key service. So we feel that there are a couple of things that would help in this. One is obviously financing, so that both finance ministers and ministers of health think about primary health care, because not many will have a double. The second is that there be these sustainable financing models, whether they're service-based or whether it is free, whether there's more taxation that's used. It needs a sustainable model. The third is that you need to be very clear about your supplies and your supply chains. I think most of you know that about 45% of the vaccines in the world go through UNICEF's doors. And so getting supplies to the right place at the right time and making sure that there's refrigeration when needed, that's a very important part of primary health care. And it is also something that we need to really talk about. So we haven't talked about advocacy, but what parents and communities think about simple things like vaccinations is very important to do with their later health care. So if you don't get it right when you have a child in front of you, it's going to be a problem. And there's a lot of vaccine hesitancy now, either due to social media or due to campaigns. So advocacy for good health for young people early on is very important. The other thing that I think we often undervalue in primary health care is it's where you hear from a doctor or a healthcare worker about good nutrition practices. So even before you've had a baby, if you're a young adolescent mother, especially in South Asia, you might be underweight. There might be anemia or iron deficiency. And so the health of a mother, the nutrition, is there clean water? All of these become a very important part of how a child becomes healthy. If you have healthy children, you're more likely to have a healthy populace. So start with children and thus primary health care.
I think, talking about primary health care requires setting priorities for public spending and deciding, maybe I could ask them, can you reflect a little bit on how is Egypt prioritizing what they will finance through these different contracted or commissioned entities? Is there a specific way that they decide what will get public subsidy and what won't, or is it more demand-driven?
Let me say the package introduced includes the primary health care. And even when we said, okay, who will provide the primary health care? We said, okay, as I said, we have 3 organizations to manage this universal health care. One, as I said, the financing one, and the second one is a public health provider. They have the facilities to provide the primary health care. But we said also, let the private sector also provide the health care and let them compete. So it is part of the package, and it is when we did many actuarial study to come up with how much we will need, the cost of primary health care was part of the overall cost of the system.
I see. And what share of spending is going to PHC, for example, in your system?
I believe we put something around 25%. However, it's a dispute between the financing agent and the public health provider, that they think, no, it has to be moved up to 40%, which we are making argument. But in actuarial study, we accommodated this cost as an average of 25% of the full cost, because in Egypt, let me say, this is a constitution, it states very clearly that universal health coverage must cover everything except some services which might be seen like
Plastic surgery or
exactly,
something like that.
exactly.
So you have to cover, so there's a package, but at the same time, there's a legal framework that says that you should cover everything.
This
the
is
most
in the
part.
constitution.
In the Constitution.
In the constitution. So
Don't
when
do
we
that
were-
if you're thinking
when we
about
were
it.
designing when we were writing the law,
lot, yeah.
we said, okay, this is a constitution. We cannot say this is exempted or something like that, except the things which it's not be covered.
Interesting. So tell us a little bit about how the packages are selected and designed in Ayushman Bharat.
Amanda, you also know more. We had guidance from you also. Just
Yes.
wanted to reflect on one
Yeah.
point she said. A very good example I can give you. We have 80% institution deliveries in India, but the first hour breastfeeding is 60% for the pregnant mothers, because we miss the counseling part, we miss the preventive part, and it's, I think, a total artificial classification of primary, secondary, and tertiary.
Yeah.
Somebody who suffers a cancer, or sorry, a heart attack,
Yeah.
the doctors tells them avoid cholesterol, do some exercise, but we don't do it at the first end, but we do it when somebody falls sick. So it's very, very important, pertinent that we should nail it down that primary healthcare has to be part of this packages. We have started initially with secondary and tertiary, and that's because we need systems to get stabilized.
Yeah.
But I think it's time that we start talking about and making the right noises about primary care and acknowledging the role of private sector in primary care. Your question was about packages. Yes, I think one of the most important scheme when we started, and I must compliment, sir, that World Bank has been a very important part as a CST. In fact, they're in the Rekha and all, they particularly gave us manpower for designing this package list and all, which was actually about 1,400 packages, 24 specialties, and it's a rate which is differential based on quality, differential based on backwardness, and differential if you're also running a medical college. So if something is certified by an accreditation agency, you get 15% extra reimbursements. So if you are in a backward area, you open a hospital there, you get 15% extra reimbursements. This system has worked well, and we have seen about many hospitals coming up in the rural areas. So I think what is required as part of UHC is proper incentive alignment. India passed a Clinical Establishment Act in 2011 to regulate private sector, but it didn't turn out to be a great success. But when you put up as a part of insurance and you have a strategic purchasing power of 500 million, hospitals are ready to get empaneled and follow those guidelines. So I think incentives alignment is one thing which the schemes can work together with.
Yeah. And we'll come back maybe to the issue of how to detect fraud and abuse, because PMJY has a really interesting system. But when we talk about these issues at the international level, you don't hear as much nuance in the imagined way that UHC is implemented. So I don't know, Dr. Pate, if you have any reflections on that. I mean, sometimes I recall that at the UN high-level meeting, there was a conversation that was like, the solution is public sector all the way. It seems like in some respects, the advocacy community does not necessarily distinguish between public financing and public provision. But do you have any insights on that?
I think we have to check the global advocacy and the value that it offers. But when it comes to translating it, we have to nuance it around country context. As we've had in India, as we've had in Egypt, as we have in several other countries, the path that countries go through their reforms, how to optimize their primary healthcare systems, that has to be localized in that sense. And the private sector is better regulated than others. The purchasing arrangements are different in one versus another, and even the endowments that countries are able to mobilize to finance the health of the populations or even the package of services are different, in addition to the epidemiology. And just to go back on the epidemiology a little bit, that the imperative for PHC and for us to reimagine it in the context of UHC is even more pressing. Not only don't we have the resources, but that you've got rising non-communicable diseases, so the model of delivery of care by necessity has to go to the lowest point where we can get the most cost-efficient services being provided. And secondly, also to bring up the issue of quality to be more front and center, because poor quality care is actually wasteful care, whether it's primary, whether it's secondary, and that with limited resources, which whether domestic or international, still we need more, but we know that we can do a lot more. And that quality agenda, I think we need to bring it front and center, regardless of whether it's public or private, because poor quality care transcends across the board.
Okay, so let me, as a follow-up to that, on this SDG 3 accelerator, tell us a little bit about how that will help in low-income countries bring together these many different flows that come into the country that are related to primary health care in many respects, not in all respects, but what will happen differently going forward?
I think there's momentum building up. Of course, the global advocacy contributed to that. Where do we go from there? A week ago, 2 weeks, the Global Fund had a very successful replenishment. That's a good marker. We're in the middle of an IDA 19 replenishment program, which needs to be really completed and complete successfully, because IDA is a key component of financing health for the lowest income countries and for the poorest people in the world. And that has to be successful for us to be able to build on this momentum. You've got Gavi, you've got the Global Financing Facility, and there are several others that will come down the pike next year. In the context of the accelerators, I think we need to align around the countries, and a subset of countries are already emerging, and we would see within the context of this national budgets and their priorities, how do we bring in the resources externally to complement what the domestic financing is going to be put on the table. The minister from Egypt mentioned that there are so many actors out there. The idea is if you have a coherent national program, then the external actors will align behind it. It's easier, it's more efficient, and we will be focused on the results that matter. Without doing that, we'll all be duplicating each other. We'll have separate supply chain systems, different ways of purchasing, and all kinds of ways of spending the resources without optimizing on the outcomes front. So the accelerators, I think, are a good avenue for us to move in that direction. And I think with Global Fund, Gavi, GFF, and the bank, at least it's a good start. WHO, UNICEF, around the table, but really concrete. This is not a global conversation. I think we've passed that stage in some sense, that we need to really talk about, in particular subset of countries, particularly those that are lagging behind, what do we do together? And in middle-income countries, upper middle-income countries, there are issues as well, and the ways of managing those also will need to be different. But for those that are key to achieving the UHC goals that we really are striving for, we need to work better as an international group, and the accelerators will help us do that.
Okay. Why is this time different, Henrietta? Because, I mean, we've been talking about this at the international level for a while, but we've seen really persistent siloing and parallel flows. How do you think, or what could we do to make this time different, rather than saying, why is it different? But what do you think?
Yeah, so it is a problem, a puzzle that we've been working with for quite a while. But it actually makes a difference when major actors get together, because then you begin to sort through what are the services that you have and how can it work. So let me just pull up two thoughts that come from this panel. So one is this notion about efficacy and efficiency of spending. So the number one request that UNICEF gets around budgets out of finance ministers is, are we actually getting good value for the money that we're spending in, let's say, a hospital system or in an education system? It's that efficacy that makes a difference. If we focus on that, that really helps to try to make sure that you're getting the services to those who need it and that you are actually doing the right service at the right time for the right person. So I think that's an area that is important. And when you get together as a group, whoever you are in the country, I know UNICEF will be there strongly, but there are others who will also provide services, trying to make those services efficient and actually get the results that are wanted. That's going to be extremely important. The second one is, the world is moving faster and faster, and digital health is on the move, and precision health. And we are, to the India example, we are in so many countries without good personal health data systems. It is not shared on the national, local, regional, and in your doctor's offices. It's true here in the United States.
Yes.
It's not a seamless system.
No.
But it is in some countries. And you can see that their productivity and their ability to look after the health of their citizens changes when they put that in. Digital health is a public and private activity, no question. And so the more that we can, as a group, pair up with private entities and really look at how technology can help us, I think it can make a difference. So efficacy and technology.
Okay, and I mean, maybe that's also about the ability of these systems to generate that information so that external groups can watch and see what happens, as we'd love to do.
It's
but,
not costly.
Yeah.
It's not costly.
Yeah.
It's very cost effective.
Yeah.
I think the Indian system, total of putting up for 500 million IT system wouldn't have cost more than $1 million.
Wow.
So it is doable,
Yes.
and we are doing it.
We need some south-north work on that
and the
here.
scheme,
I don't want to talk
the
about
scheme
the
is
amount.
totally portable.
Yeah.
A person from a North India going to a South India and fall sick there can get treatment in any of the empaneled hospitals. And it's total, again, cashless, seamless, paperless.
Yeah. The other thing that's so unique about India is the unique ID,
I think
enables you to link the
this
whole
is what
patient
the
experience.
Aadhaar
but-
man Nandan Ilkani helped us.
Yeah, I
That
mean,
we,
there's
we ride on that.
difficulties, but-
About 96% of Indians have a biometric identity.
So in the Egyptian reform, do you have that kind of ability to look at the efficiency, for example, of the 10 hospitals that you're contracting in a given governorate? Do you have that kind of visibility into the spend and performance data?
Let me talk about two issues here. The IT system, which will be critical and crucial for the success of a universal health insurance, referral system, claim management, reimbursement, database for those who are insured, and also for medical file and all of that. All of these must be integrated and must be available because, yes, people can move from the south to the north, east to the west. So this data must be available. This is number one. Number two, the efficiency of the system. And this is very important because when the private sector and the public sector are competing, this will be crucial. Because for me, I'm not caring about how much you pay for the doctor or for the, I am caring about two things. Number one, the quality. Number two, the satisfaction of the patient. Because if the patient come back to me and say, oh, you've paid this hospital and this hospital did not deliver, I investigate that. It is true. Thank you. You are out of the system. When I have 100% of the population, 95% of the population, it means you're going to shut down. Because I'm the only one who provide patient. I have all the customers. Egypt has more than 100 million citizens, and I'm assuming that by 15 years from now, we will cover more than 115. It means I have all the customers. So you want to benefit, so you have to be efficient. The third thing is that the way we costing the benefit package. We decided to create a committee. This committee comprised of the public provider, the private provider, independent. So they can set that. This is a committee which is continuous one. Every day they can meet. And they decide about the changes. And they ensure that it is fair priced. It is fair priced for private, public, and for others. And it is ensuring the quality, because our experience, one of the experience is that, okay, I reduce the cost because I have financial difficulty on the expense of the quality.
Yeah.
We said, no, no more.
So how often are you updating prices, and how much do these hospitals complain about that process?
Look, it is a new experience.
Yeah.
We haven't got to the point when they complain. However, how much this committee meet, let me say, they are on call. So whenever we get complaint about pricing, about something, we call them, please sit down, and it happened over the last 3 months because we started the system in July. But as you said, our experience, previous experience with the old system is that you put the price, and private sector say, oh, this price doesn't cover even the 50% of the real cost. Okay, what I'm gonna do, one of two things. I'm gonna compromise the quality, okay? Or I will ask the patient to pay the difference. We said, this will no longer be allowed. Don't ask the patient and don't compromise the quality. How can we ensure that? Come and sit down with me and decide on the price. Once you, private, public, and others, and the independent expert decide this is a fair price, so we have to commit. If you don't, you are out of the system.
Well, I know I visited your offices in Delhi, and there was a visit by the Association of Private Hospitals while I was there. What were they asking about while they visited?
Well, that's a global tussle. They will always say that prices are low. But the point here is that this gives us a strategic purchasing power. But we also must realize that success of the program lies in having everyone together. If you don't get private hospitals, then it becomes again only a public program. So you need to have increased accessibility, availability, you need them. At the same time, we told the private sector that, look, you need to change your model. From low numbers and a high profit game, please move out to a high numbers, low profit game. And today we are covering 500 million, tomorrow we will cover another 500 million. Then you won't have even patients to visit you unless you become part of the scheme.
Yeah.
So, but they had some genuine issues. We had some packages which were absolutely low. So in the first year, on the first anniversary, we did a full revision of the packages, and the team was very helpful, and we have now revised about 250 packages price upwards, 57 packages downwards. This will be a continuing exercise. This is a committee of specialists. There are 24 specialist committees for 24 specialists, which keep on doing every year. But we wanted to give the message to the industry also that we are evolving. We are not like once decided it's shut and open case. This will keep on changing. But I agree, if you don't have the right pricing, the hospitals will cut corners. And we have a very, very good grievance system. So every person who gets treatment gets a phone call. So we have a 600 operator 24/7 system working in 12 languages, calling them. Every patient getting 12. And all complaints which have come, it's very small, 1%. But of the 1% complaints, 93% they were asked money. So what we did, if they asked for money, we did an inquiry. We put the list of those names on the website. And we are naming and shaming them. These hospitals have asked for money. Till this is proved, for 1 month they are suspended. So then suddenly their chain gets discredited. Some of them are in the stock exchange. Now things started falling. So one issue of transparency and working with data is go online as much as you possible. Do whatever you can do. We got a call from the Prime Minister's office saying, why are you, this is giving great discredit to the scheme, but then it's fine. In the long run, this will help the scheme only. And second, about the frauds, yes, the one thing about the social health insurance, especially in India scenario where it's all paid by the government for the bottom 40%, there are chances that people can game the system, especially if the patient and the hospital, they collide. So then we have a very strong analytical system. We went for a global tender and asked for POC, proof of concept, of the 5 top companies of the world. Optus, SAS, Microsoft, they all came. They put up their plans. How will they find triggers? For example, we found that somebody was a male, had a hysterectomy shown there. Somebody who had done a left eye knee replacement was done after 3 months again. Could be possible, but these are triggers. Sometimes you see that there are 10 hospitals in an area, only 1 hospital patients are going. Is it really good, or is something else is happening there? Sometimes we see that same doctor is shown at 3 places at the same time because we have a medical registry linked to it. I think huge data is being generated. It's huge work, but with data, it's possible to at least move forward and control it.
Yeah, that's so interesting. I really want to ask some questions about, okay, so if people can choose their hospital, what happens if no one chooses the public hospital, but they're all still on your salary rolls at the state government? But I don't want to dive into all these, not a small issue at all, because I want our audience also to have a chance to ask questions. So let's collect 3 comments or questions from the audience. We'll start here and then in the back. Do we have our... they were thinking it would go on for more time. I'm accelerated. Well, maybe you can tell us about the my hospital question while
Yeah, I think,
we go to our first question.
One important thing of this scheme is also it's meant for public hospitals. So what we told public hospitals that you will become autonomous. With the claims which are coming, you can run your hospital. Rather than having line budgets coming from the ministry and getting entangled in a bureaucratic mess, the hospital gets claim. So we said 75% claims will go in a flexible pool, spent on HR, manpower, instruments, maintenance, and the 25% actually goes as incentive to the doctors, nurses, staff, MTS. So now we can see evening deliveries happening, cesarean sections happening, even at the night, doctor is ready to come because he's paid for that extra, which becomes part of the scheme. So I think this scheme is not only for private, but for even for the public sector. And many of the hospitals in India, in Jharkhand, have got about 2 crore rupees, which is about 0.2 billion in 1 year rupees for claims which they have generated. And then the same can be used for upgrading the hospital. And this also gives, if I'm a provider of a hospital, my ranking of hospital comes very closely. If there are 10 hospitals, 5 have got very good claims, that means they are functioning. The other 5, I need to give them a warning. You're not working. Why people are not coming to your hospital?
And then?
And then?
Okay, we'll come back to that. Okay, so right here in the second row, please say your name and where you're from.
My name is Deirdre Lepin. I'm proud to say that I'm a past staff member of UNICEF, among other bilateral, multilateral organizations. I've also worked in the private sector in the area of health and development. I'm going to change the subject very slightly. I hope Amanda won't mind. But we were talking about the issue of finance and the issue of waste. And I was thinking that there's one aspect of finance we haven't touched on, and that is human capital and the investment that so many countries make in the human capital and the training of health staff and what happens to many of those staff. If, as a person who's visited hundreds of rural health clinics, particularly in Africa, the one thing that I notice is the absence of qualified staff. And my question is, have you given thought to what we can do to reverse this trend of staff who are trained and who have used the country's resources for their training and then depart? Sometimes going back to do health clinics or something of that sort during their 2 weeks of vacation, which is very lovely, but this does not solve a fundamental problem of staffing.
Okay, thank you. In the back row, yes.
My name is Jide Akintunde. I'm from Financial Nigeria, Lagos. My question is for Dr. Alipate. As I walked in, I heard you say that the local or the national authorities should be more responsible for delivering health outcomes in their countries. And I know the good work you did when you were in Nigeria. But now on the other side, I just would like to know what your thought is in terms of how to weight the contributions of national authorities vis-a-vis the international stakeholders that are also working in national health spaces around the world. And then the second one is for the national authorities, they can be brought into accountability, maybe through elections, or perhaps just simply pointing out that they have failed to deliver service. So there is a clear accountability there. But for the international stakeholders, working in the health space. How do we make them accountable? Thank you.
Thank you. Good question. A third question, comment? Go ahead, Prashant.
Prashant Yadav, Center for Global Development. My question is about how to organize the agency, whether it is the National Health Authority or the primary healthcare agency in Nigeria. Should it be a part of the ministry? Should it be independent? Should it be quasi-independent? And any experiences, especially Dr. Pate and Dinesh. Thank you.
Yeah, let's start with that. We'll come back out to you, but let's start with that last question, Dr. Pate, on this question of the autonomous agency versus not. And then the other question that's related is how much of the money in the system goes through that agency versus other entities?
When you, country after country, the structure of the health systems and how they are governed differs. The federal system is different from a unitary system. And so the role of the institutions that you have in place in Nigeria is going to be exactly very different from how you have it, let's say, in Ghana. How you have it in Pakistan will be very different from how you have it elsewhere. So you have to, so the governance context in the country drives how you position the institutions. Regardless of how you position them, how they are led and managed is quite important. And we haven't paid sufficient attention in terms of the management of those institutions to have the strategic direction right, but also to be able to execute on them. That's more important than really anything else, I think. So that's on that. But there are a couple of questions that have been raised that I will also, the two other questions that I would like to touch on. One is on the human resources bit. I think it's a very important one. But when you look at countries, there are many dimensions to the problem. The intra-country distribution of health workers is as significant as the shortage or the exit that you have. Even within the sectors, the public and the private sectors, in many countries there are lots of health workers that actually are in country, but they work out in the private sector. And so as we begin to reimagine primary healthcare systems and what it means and how technology comes into play, what does the nature of the frontline health worker needs to look like going forward in the face of limited resources? And how should they be trained to be able to deliver what we need to have delivered in the new configuration in terms of where we're heading with UHC. I think those are important conversations on that.
Can I ask you a little follow-up question to that? I mean, in some ways, the reforms that permit private participation are to acknowledge that reality that many of the human resources for health are actually in the private sector.
Yes.
Is it just a strategy, in a way, to access that fuller set of human resources in the country?
I think it's almost a necessity. If we look at where we are today, and we're saying that we have a goal that many countries are not likely to meet. If we really are serious about getting to the UHC goals, then we need to rethink how our systems in the front lines operate and how they are linked to hospitals and how we finance them, including the human resources. Because a major constraint, 80 million gap in human resources and the existing resources are not trained. So there's I think a big reform agenda, and I'm glad WHO is picking up on that, and we will be collaborating with WHO on that with countries to figure out how to do that. I think Jide asked a question, and here I want to acknowledge the leadership of Egypt, actually, and the government of Egypt and the minister in terms of trying to bring in under the AU, the health and finance ministers, to really focus on this, coming out of the report that the bank produced in June at the G20. Because at the end of the day, the presidents and the ministers of finance and the ministers of health have to make a conscious decision that the health of our population and the UHC agenda is important for us, and that decision gets translated into budgets of the countries. Now, the African leaders have started an initiative led by President Kagame. I think that's an important signal that at least on the continent of Africa, there's traction on that. Let's see over time the scorecard and how that gets used to drive action by national leaders to get more resources, while we're also trying to be efficient in where we allocate the resources. I fear if we go towards higher level facilities in urban centers alone, we will be skewing the system towards caring for increasing numbers of NCDs and complications at a higher cost and leaving the front lines to atrophy. We have to balance that with trying to figure out the primary healthcare systems and how they are financed efficiently at the quality that they need, and the backstopping that the higher levels of the health system need to provide.
Agreed. Are we asking too much from sub-Saharan African countries to do, because urban areas are growing, demand for healthcare is growing, there's a lot of need for, as we talked about, dialysis and things like that, and governments, they really feel they must cover those things. Those people are in their health facilities now. There is a trade-off with rural primary health care, which has traditionally been the ambit of aid, for example. So, not always, of course, but are we asking too much, I guess is my question, or what can we reasonably expect? Is it right to do dialysis now? In a way it is right, but it's not the most cost-effective strategy for sure, and it's not primary health care. But what do you say to those governments that make those hard choices?
The point that I'm trying to make is that the locus of that decision remains at the country, at the national
Absolutely.
government level.
Absolutely.
We cannot. That's sort of where the legitimate locus is for. So a few years back in Nigeria, when you look at what Nigeria spends on health compared to other countries, we are spending more in Africa, but we're getting less. And so how do you reprioritize so that you actually get more within what you're already spending? So when we launched the Saving 1 Million Lives initiative, it was really around how do you prioritize working backwards from the outcome that you want to accomplish, and how do you make the system function so that you get there? Again, what are we solving for? It's actually coverage, but also coverage at least improvement in health outcomes. So the global community can help, should help, and I think we've seen that manifested in Lyon a couple of weeks ago, and we would see that hopefully with IDA-19 replenishment, which we are hoping that will be successful, and the others that will come along the way. But that's a complement. At the end of the day, the decisions like what Egypt decided recently, I think it's an important signal at the national level how to make progress. And the African leaders, I think, are waking up to that, and they should really build on that, actually.
Yeah. Henrietta, I'll let you answer these questions, but I also to think about, you're as an advocate for children and children's health and access to health care, these issues are particularly acute, right? How do you see these hard trade-offs that governments are making, and how to keep the focus on what will make the most difference for kids' health?
Well, Amanda, to your point, you are absolutely on the right focus, which is that if you're a government minister and if you look at your system from a child's point of view, you will probably get your investments right. But if you don't, if you take it from the another angle, you just may miss a lot of things. If I could turn to the very good question that came about healthcare workers, one of the puzzles we have in the world today that the World Bank is now trying to address is the quality of learning in schools. And 60% of the children that are in primary or secondary school today will not be literate. So the bank this week has just announced an initiative for addressing learning poverty so that you can read a paragraph and understand it by the age of 10. If we do not have literate people in a society, it is going to be hard for them to do anything. And because we talk to lots and lots of young people around the world, what they are most worried about is that they don't have a modern education and that it's not connected to a skill. But there are two professions that we know are going to be needed in the 21st century. One is healthcare workers and one are teachers. Both are going to need literacy. So unless we address some of these basic fundamentals like literacy, it means that everyone, whether you're private sector or whether you're public sector, you're going to go after these individuals and they will be drawn away because maybe you're not paid as much. So for ministers, what you pay and how you reward and incentivize the talent will be extremely important because that's where talent will go. It will either be in the health sector or in the teaching sector, in the business sector or somewhere else. So it's a key issue for healthcare to work in this century. It's the people.
Yeah, but I definitely think that idea of like starting with the person and how they see the health system is a good place to start. Minister, can I ask you to reflect on this issue of the autonomous agency versus, say, a Ministry of Health running some of these systems? Egypt has obviously opted for an autonomous agency that you were part of the setup. How do you see the sort of politics of that? Does it create a virtuous cycle? What are the bad things about it?
It is not easy because every minister will always want to keep as much under his leadership as much as he or she can. But let me say, we have to study the experience. Every country has its own way of going forward and has to learn from the past experience and also the future vision. So for Egypt, our last experience says if these entities will continue under the supervision of politicians, so all the decision, all the important things will not be managed professionally. It will be managed driven by the influence of the politicians. We have to keep it away from that. Definitely. We have to keep it away from that. So we decided to make the three entities managing the system away from the government financially and even from the legal point of view, administrative point of view. Even the organization which will be responsible for inspection, for licensing, for accreditation, we decided to be the supervision of the president himself, nobody else.
Wow.
In order to give it a strong influence about how the health system will be managed. And the financing agency, we said it must be away from the influence of the Minister of Finance and the Minister of Health. And it has to work according to sustainability, financial sustainability, and satisfaction of the patient, if we don't do that, it will continue managed by a telephone call from the minister. We don't want to do it to continue like that because this is our experience. So we've made that decision, and this is the case. Still, with the first implementation, the Minister of Finance influencing the system practically, and the Minister of Health influencing the system practically. But from the legal point of view, it should not be the case. However, we said, okay, let us first of all get the three entities operating, and once they are operating, definitely the law will be governing. This is number one. Number two, the issue of healthcare workers. This is critical. Why? Because in the case of Egypt, Egypt is a country with the highest number of doctors in the region. But where they are not in Egypt. They are in the Gulf. Why? Because they are well paid there. So we educate them freely. Education at the university in Egypt is free. And we train them in the public hospitals, okay? And after that, and even if they take diploma, master, PhD, they leave the country and go where they can earn more money. It is fair to say it is their right because they have families and blah, blah, blah. How can we change this? How can we convince them to stay and provide service in Egypt? I believe, number one, good salary. Otherwise, we are making joke by saying, oh, it's a national service and it's your country, it's your people. No. Think about paying them the good salary. Think about giving them a good environment for doing their work. Think about training them well. This is what we try to do with the new system. So the current salary in the public hospital multiplied by at least 10 in the new system, at least 10. And we said, okay, we're going to offer you this on an annual basis, on a contract. By the end of the year or 3 years, if you are happy and we are happy, we continue. Otherwise, go back to where you come from with a public hospital, or you travel back to the Gulf. It's up to you and it's up to us. So we try to be realistic, to sort out and to face the challenges.
So they were civil service employees, and then they were on these different kinds of contracts under the reform.
Exactly.
And are you seeing a change in retention?
By the way, even when they left the country and went to the Gulf, they still our civil servant. They're still keeping the job. Okay?
Okay, good that you're focused on this
And
issue. That's
when
good.
they are in the country,
They work for the private.
they go to private sector. They
Yeah.
get the salary. At the same time, they are on the payroll for the public hospitals. And by the end of the month, they get, because we don't offer them a good salary. So what they do, okay, they come 2-3 hours a week to the public hospital, and the rest with the private sector. So we have to be realistic and to know what is the problem, how to sort it out. So we said, okay, let me give you even better than private sector. But I cannot give it to you on the payroll of the public sector or the budget. I will give it to you from the new system, which is not the part of the budget. It's financed outside the budget. And by the way, as I said, from social insurance contribution, from the state subsidy paying for the poor, and the earmarking tax, and we imposed what we call it solidarity contribution in the public business to the system, and everyone represents third of the sources. And as I said, we've done 3 or 4 actuarial study to ensure this system will be sustainable and have the mechanism to adjust itself when there is imbalance in the financing. It will adjust itself to continue sustainable.
That's like you're an actuary too, right?
Yes,
So, I mean,
I'm an actuary.
that's what you need, an actuary
I'm
in
an
charge.
actuary.
And I think this is a very creative solution to a problem that exists in a lot of different countries around absenteeism, working in multiple sectors at the same time, struggling to pay a living wage. It's an interesting experience. Dr. Dinesh, you have some answers to all of this?
Replying to Prashant's thing, I think, Prashant, we started in 2008 Rashtriya Swasthya Bima Yojana, which was run by the government. This Ayushman Bharat, we started initially as a society run by the ministry. And then in 6 months, we graduated to an autonomous National Health Authority. So the answer is very clear. Ministries should let things go. Implementation should fall outside the purview. There should be policy, there should be implementation. Implementation should. So now today, we have an NHA governing board which takes all the decisions, including package pricing, empanelment guidelines, de-empanelment guidelines, as well as penal provisions. And whole budget is rooted through this, the whole budget. So the one agency which is responsible as well as accountable. And it is under the purview of the CAG, the Accountability Commission, which is there, and reports to the Parliament for that.
But let me ask you, so that's true, the full budget of PMJY, but there are all these big flows at the state level as well due to the fiscal transfers, and then there's
Right.
the flow
So-
from the national.
Absolutely. So what we have
Ministry
done,
of Health.
is we have opened escrow accounts with the states now. So in escrow accounts, they can't divert the money. The money can be only given to the hospital in time. So that's one way to check what hospitals in the states are also doing. Replying to the question of, I have a very different way of thinking of certain things. When you talk about budgeting and finance ministries, ministers, and all, there are competing demands for this. Now let's understand in India's scenario, we spend 1.15% of GDP. I know it's very low. Of course, GDP is doing very well. So GDP has doubled in the last 10
growing,
years. Where is the money coming for health? Health, India spends 3.5%. 1.15% is coming from government. 2.4% is coming out of pocket, 70%. Now, when we went to the finance minister, we said, this 2.4% which is coming out of pocket is wasteful, inefficient, costly, and they're not serving the purpose. If we can spend about half of this as a government and as strategic buying outside the government as a demand side scheme, it will do wonders. So we have been promised that by 2025, the budget will increase to 2.5% of GDP. And this is how Ayushman Bharat has been created. The budget is coming. So my point is, if government is not spending, somebody else is spending. And if somebody else is spending, I'm not talking government. Government means the government provisioning. That's wasteful. As compared to a perfect purchaser-provider split with the strategic buying could be much, much more useful. And this is perhaps the message which we gave, and the Prime Minister was on it, saying that, show me to do it. That's why we were so fast in 1 year. We wanted to show that we can implement this provided if the political will is there. And if you have a minister like this who has a political will as well as an executive will, I think things can go wonder.
I'm moving to Egypt. I think both of these took an enormous amount of political will and the desire to face down all of the competing pressures. We'll see I think the other key is to evaluate. I don't know if the World Bank and UNICEF will be doing evaluations of these big universal health coverage reforms and how they do on health outcomes and out of pocket. There was talk of an accountability framework at the UHC high-level meeting. Where does that conversation stand? And what will it be your agencies that will be doing some of that, or how do you see that?
So this is definitely part of the framework, and it's a very important part. So WHO and UNICEF and the bank often work together. And part of what we want to be sure is that we are measuring to see what's working and what isn't working. I mean, the world needs to learn from all of these different approaches. Insurance is something that is being discussed broadly in the world today. So is what actually should be covered in primary health care. Could it be free for every child in every country? But the issues are very interesting and complex and interrelated. So measuring them will be very important. So we have a whole data and data analytics. It'll have to be public and private because the private sector is catching many of these. But it's very much part of it, and it will show us the future. The other thing that I think I'm hearing on this panel, Amanda, is that healthcare is also moving to empower the individual. So the individual chooses the services, they choose the insurance, they choose their coverage, but they're being more and more empowered. A lot of that will come digitally, and it will come into your home on your cell phones and on your pads. So we have to also change with that the empowerment of the individual family is going to be extremely important, and you can see it now starting to happen in a number of countries. It can be very efficient because people then get the services that they want when they want them.
The bank, WHO, UNICEF, and others participated, collaborated on the Global Monitoring Report for UHC, which was also launched on the side of the UNGA. I think the message is clear that access is improved, quality is poor, financial protection is not heading in the right direction. I think we have an opportunity using such mechanisms to track over time. It's on us. At this moment, we are not really on track for SDG 3 and for UHC. What do we need to do? And that is on countries, but on us as a global community. The Global Action Plan and the Sustainable Accelerators, the 7 accelerators, give us an opportunity to concretely collaborate and see how we make progress around countries, particularly those that have been left behind and within countries as well. So I think that's an important element for the global accountability that we've committed to these goals, and we should take stock of them.
Okay, great. We have time for 3 more questions, comments, quickly, right in the front row. Remember to say who you are, where you're from.
Hi, I'm Anirudh Krishnan. I study at the Yale University. I study in global affairs, and I'm here from Singapore.
From Connecticut. Okay, go ahead.
I'm wondering, both of you have really mentioned a lot about value and moving toward in this transition towards universal health coverage. While we wait for systems and for financing to catch up, assessing value is critical, and ensuring that we direct resources towards the most effective interventions and programs. But we're working with constrained budgets and constrained information, right? And cost effectiveness analyses, monitoring and evaluation is very expensive, and it's expensive to do it right, and it differs from one country to another. And so when countries are transitioning into UHC, how do they prioritize between doing this evaluation work, doing cost effectiveness analyses to check that it really is more valuable than the next best alternative, and actually using those resources to deliver, to provision services?
Okay, great. Thanks. We're going to come to your question. We have to say goodbye to the minister, an incredible finance and health person all together. So don't forget to leave your microphone. Thank you very much. Don't forget to take his microphone, though. Okay, second question just behind you. Great.
Hi, my name's Joe Millward. I'm actually a master's student currently at Johns Hopkins. So first off, I'd like to just thank all of you for talking today. It's really been insightful. One question I have, I think a good point that you brought up, Henrietta, is when you think about this difficulty just in defining PHC, right? Moving forward with that, when you think about how you're developing these packages, especially moving into the future, my question revolves around, for these UHC systems, how do you ensure that you have proper monitoring and evaluations of both disease burden as well as outcomes? And what information do you see as being the most fruitful to actually leverage in priority setting moving into the future as well?
Okay, great. One more.
My name is Yemi. I'm a health system specialist from RTI. Thank you so much for the interesting discussion. My question goes to Dr. Arora. I'm really impressed with the progress you've discussed about what India is doing now. My question is that, so you say you move from a supply side system to a demand side. What are the things you're doing to ensure the system is not overwhelmed? That the system is not overwhelmed, the supply is matching the demand. You mentioned that you are incentivizing hospitals to start in rural areas. Are there other things you're doing to ensure the system is not overwhelmed by the increased demand? And secondly, do you think the financing available now is sustainable in the long term, even beyond political cycles? And why do you think so?
Okay, so let's start with you, Dinesh. Maybe you can even start with this last question and work your way back.
Yeah, that's fine. Thank you. I think it's a very pertinent point for any health insurance demand-driven scheme when you talk about sustainability. And that's why I said, one, we have linked it to the cess, which is coming every year. The GDP is buoyant. It's coming, but I fully agree. What we are doing right now is reimbursement of secondary and tertiary hospitalizations. And that can be a pervasive incentive only to get OPD patients converted into IPD and doing it. So the essence lies actually in tying up with the primary health care. And we have been running a lot of pilots for this. For example, if a delivery case comes, a delivery case which has gone for 4 or 5 antenatal checkups will get the full reimbursement money. So the onus is on the hospital to see if they want the full reimbursed money, they should also get into the primary care. So we have a global budgets of Maryland or the Philippines model of how primary health care can be done. In fact, the idea right now is to link or purchase primary health care along with secondary and tertiary to make the scheme sustainable. Secondary and tertiary, only secondary and tertiary will not make this scheme sustainable. I can share one experience. My mother had come to America for about 2 weeks back, and she was walking in a park and she slipped. And she was a small cut, and I'm a doctor myself, also being an administrator, though I'm doing my economics at Johns Hopkins. So what they said, I wanted them to get a tetanus injection. I called up one of the hospitals, and they say, oh, she's 65 plus. We will do full MRI scan, CT scan, and this. Do you have insurance? I said, yeah, she has insurance from India. I'll need to check up, but it's today right now 6 o'clock. So can you just give a tetanus injection? No, if you come, you have to deposit $10,000 for 1 day ER, and then you can look into this. This is 2 weeks back at Baltimore right now.
Sorry.
And I called up Walgreens. I said, guys, you're allowed to give an OTC injection? He says, yes. Do you have insurance? I said, no. Okay, $74. I said, I'm coming right now. So that's what I was saying. You need to build on systems to make it sustainable. Otherwise, this will go 1 trillion, 2 trillion spending and won't affect the results. We are very conscious of this factor, and that is why the next on agenda, if the challenges is biggest challenge is to dovetail primary health care, how to make it a comprehensive. So moving away from a pick and choose selective systems to a comprehensive system is the most important agenda, and which now the Indian NHA will look forward to. And I think we request support of everyone in this, because this is something which we are running pilots. We are still not ready with the model, which one to be, to choose for that area.
Excellent. Okay. Yeah, go ahead.
I think on the 2 questions on evaluation, I just agree with that. I think, as we say, moving from less prescriptive to more adaptive approaches to get into UHC, it implies that we have to learn as we go as well, and have independent as well as intra mechanisms for learning, for evaluating what are we learning and where the course corrections will need to happen. And governments need to invest in it, but also it's a global commons that we also have to really see, do more in that. So I agree with both comments, basically, on the centrality of that.
Great. Maybe, Henry, you can give us a closing remark to inspire us all as we go home. Henrietta, also, I actually didn't realize that you had been head of the Mint in the U.S. Treasury, so she also combines both finance and health sector expertise. But what advice would you give as we go back out into the world into meetings with health and finance officials around universal health coverage?
All right, so Amanda,
No pressure.
this may be just a small answer to it, but to a couple of your questions, I would always start with an assessment. At least know what your problems are. This is back to what Dr. Pate has talked about. It's very important to actually know what you're trying to solve. I have seen some exceptional healthcare systems that have started because people said, we don't have enough money, we don't have the right skills in the right place, we can't look after our people, so this is hopeless. But what instead they created were systems where, let's say in Kazakhstan, primary health care went everywhere in this massive country, and the regional hospitals became the ones where the doctors were there for more complications, and they could afford helicopters bringing in those few patients that needed that. They are completely digital so that you can see your and your children's healthcare records. You can take them with you. They're portable. You could even bring them here. And so you can change things. This system can change. So if we get very well informed, we use the accelerator, I think we can really achieve universal health coverage. And to us, most importantly, primary health care.
Excellent. Well, thank you so much to our panelists. This was a great conversation. Thank you.